Thank you, Sabas, for your help. So now the topic is recombinant TSH versus thyroxine withdrawal, which is not difficult to. These are the different aspects I'm going to address in this presentation. The remand ablation, radiotoxicity, and biokinetics using these two modalities, morbidity of thyroxine withdrawal, and the use of these two preparation procedures for diagnostic follow-up. Let's go to remand ablation. So the best way to address this controversy is to perform a trial. This is what these authors or this group did in the past, and almost 10 years ago. They performed a randomized, controlled prospective trial with these objectives: determine the ablation rates using both modalities, evaluate the safety profile with these two modalities, and compare the uptake and rotation of radioiodine with these two possibilities. These are the characteristics of the patients included in the trial. It's important to notice that more than 1/3 of the population included here presented N1 or lymph node metastasis in both groups, so it's important to note. But also that none of the patients included in this trial had metastasis, distant metastasis. Just, no, how you say? Bless you. Okay, these are the results in terms of, well, in this trial, they also use two ways to define the endpoint. One was the remand ablation rate when the uptake of the whole body scan performed after the treatment is negative. So there were no difference, 100% in each arm, in each group, using withdrawal and thyroxine in this case. When the endpoint was stimulated thyroglobulin less than 2, these are the small differences in this group, so, but not significant, so there are no differences in terms of remand ablation rates. But what is important in this trial, one of the conclusions was that the amount of radioactivity to the blood was smaller and significantly smaller in the group of recombinant TSH stimulation when comparing with thyroxine withdrawal. So in conclusion for this trial, we can say that the use of recombinant TSH for remand ablation is comparable to this thyroxine withdrawal, and the radiation dose to the blood was significantly lower using the 2 injections of recombinant TSH. There are 2 papers that were published in 2012, 2 trials, one the French and the other was the British. And this is part of the results have been presented by Marcel in the previous talk. So there were 4 arms in this trial. The people or patients who were treated with a low dose and also with recombinant TSH, and with low dose but thyroxine withdrawal. So in this trial, we can answer the question with low and high dose, because the patients also were divided in high dose and 2 different forms of patient preparation. It's important to notice that the the endpoint in here, just to define ablation rate, was the ultrasonography in this case, plus the stimulated thyroglobulin using recombinant TSH. And in those patients with thyroglobulin antibodies, they perform the post-treatment, or the rate of ablation was viewed or using this whole body scan after the treatment. So here you can see the rates of complete ablation at, as you mentioned before, 6 to 10 months, which is a very short period of time. But anyway, there was similar between those using the different possibilities, the 4 arms. Remember, there were low dose, high dose. Low dose was 30, high dose was 100 millicuries, and using recombinant TSH and thyroxin withdrawal. So there are no differences in terms of complete ablation using these parameters. What about the adverse event? That's interesting. Look at the lacrimal adverse events. So those with thyroxin withdrawal were higher, significantly higher than those using recombinant TSH. But when we look at the salivary gland toxicity, the toxicity was increasing depending on the dose, and also using the thyroxin withdrawal was higher than the recombinant, and also in this case or higher with higher doses, but there is a difference between these two procedures. So there are differences between the lacrimal and salivary glands toxicity depending on the dose and the procedure for patient preparation. And what about the quality of life of these patients? Well, using small dose and recombinant TSH, the quality of life in these patients were better or performed better than the rest of the arms. So in conclusion for this trial, we can say that similar efficacy of thyroid radioablation after preparation with either recombinant TSH or thyroxin withdrawal using either low dose and high dose. The therapeutic radioiodine intervention should be non-toxic and should be maintain quality of life, which is better achieved by low dose and of course, recombinant TSH. And the symptoms of hypothyroidism and quality of life significantly better with eurothyroid groups. And the use of recombinant TSH with low dose for ablation represent an effective and attractive option for low-risk patients, this has been talking before. The second paper is similar, so the design is quite similar. This is the British one, but in this case, they use the whole body scan, radioiodine whole body scan, to define which is a complete ablation or not. And also, of course, using the thyroglobulin determination using this by means of recombinant TSH. So in this case, there were also no differences between the 4 arms in terms of ablation success. Remember, they changed the parameters, the whole body scan in this case. The adverse event also were lower in the groups with low dose and recombinant. Here you can see an example using high dose with thyroxin withdrawal and using high dose with recombinant TSH. The percentage of events are more or less similar, a little bit higher with this. But when they use a small dose and thyroxin withdrawal was 25% by 60%, so it's smaller in this case. So the adverse events are reduced by this preparation and also those dose. So in conclusion, for this trial, the ablation success are similar again, like the other one, using these two parameters. And patients receiving low-dose radioiodine and recombinant TSH had fewer early side effects and significantly better quality of life than high dose. What about radiotoxicity and biokinetics? Well, some of these results have been presented previously in the first trial. These are the uptake in the remanent, were similar in using these two procedures, so no differences. But look at the blood dose, very low or lower than the thyroxin withdrawal. So that's an important for toxicity, possible toxicity. And when they look to another possibilities, like this adverse event on to the testes, ovaries, hematologic, and salivary glands, in this case, the data, the elevated FSH in the group of thyroxin withdrawal were higher, but also in the rest, and these cases are significant, like insuladenitis, which disappear very early after, some months after the treatment, but in any case, the percentage of side effects in salivary glands were higher in the group of patients with thyroxin withdrawal. And we have been talking in my previous talk about the clearance of or the importance of the urinary excretion, and Urania asked me about the use of TSH, the recombinant TSH in these patients. So this is the explanation for that. So the cumulative urinary excretion activity is higher, so the release are higher and it's more rapid. So than the patients with thyroxin withdrawal. So in terms of urinary excretion of radioiodine, this is higher, faster in patients with recombinant TSH. And the dosimetry in different parts of the body, for example, in lower large intestine or large upper intestine and stomach, ovaries, look at the data. So the amount of radioactivity that are given to these normal unaffected organs are much more higher using recombinant, using thyroxin withdrawal than recombinant TSH. So using recombinant TSH result in a longer biological half-life in the of radioiodine in the thyroid remnant, but a shorter biological half-life in the rest of the body. So is the thing we want to afford. And using recombinant TSH is low radiation exposure in most organs versus thyroxin withdrawal. Another question that I want to address is the possible morbidity of thyroid hormone withdrawal. Here is another paper where you can see very clearly the quality of life results in this population. So there is, as you can see here, there is a decrease in quality of life in different topics. They are answering physical functioning, role of physical vitality, social functioning, mental health. So there is a decrease, while the rest of this aspect of these topics are normal in the population using recombinant TSH. Diagnostic follow-up using these two procedures. So this is another study. They studied 340 consecutive patients with differentiated thyroid cancer previously treated. And here you can see the effectiveness of using recombinant TSH for follow-up using thyroglobulin as a test. So in this case, they didn't find any difference between the group of just recombinant TSH or recombinant TSH plus ultrasonography in terms of specificity, sensitivity, or positive and negative predictive value. So human recombinant thyroid stimulating hormone in diagnostic follow-up is valuable in patients with potential and persistent disease to confirm presence or absence of disease. The most commonly reported adverse reactions using this procedure are the nausea and the headache in only 12 or 7% of the patients, respectively. And if you want to check these possibilities, you have to go to the SMPC or the Thyroxin that is published or is available in November 2012. So regarding the IAEA guidelines, we are being presented here, and regarding the preparation of the radioiodine therapy, they say that for low risk, withdrawal and recombinant are both acceptable with this dose, they suggest. In intermediate risk is acceptable both procedures, so there is no difference. They accept all the trials and the papers published in this way. But in the high risk, they say yes with thyroxine withdrawal, but no for recombinant TSH because there are no enough evidence to see that. So, and in some patients could be considered. So there are some doubts about, depending on the risk of the patient, with higher risk, they have some doubts about the usefulness of recombinant TSH. Let me show you an example. This is an old patient, 81 years old male, presented with metastatic papillary follicular variant thyroid carcinoma that affected bone, lung, lymph nodes. He has been treated with different treatments, for example, surgery, bone radiotherapy, because he had a very high lesion in the spine, and also we have given radioiodine treatment for 4 times and with accumulated dose of 700 millicuries, and also this patient has been treated with sunitinib. We performed a FDG PET CT that showed an increase or progression in bone, pleural, and lymph node progression in the mediastinum. As you can see here, different small lesions in the pleura and also in the mediastinum. And when compared with the previous one, there is a clear progression. So we have this lesion here, very clear. It's a nodule in the mediastinum. And we decide to give 200 millicuries for this patient, 81 years old, using recombinant TSH because he's an old man with a bone metastasis and low quality of life if we stop the treatment with Thyroxin. So here you can see that most of the lesions had a high activity in the radioiodine post-treatment scan. And also this small lesion has a very high activity with radioiodine. So we perform a new PET FDG scan some months later, and you can see a clear response after the treatment. So even when combined with sunitinib, radiotherapy, surgery, we can add an additional doses, high doses in this case, of radioiodine using, in this case, recombinant preparation, and also the thyroglobulin is decreasing in this patient, but look at the data is very high, but anyway, we are decreasing many times, and also the quality of life of the patient. So, what about this population of high risk or intermediate risk? These are the results in this study published some years ago, 4 years ago, or 3-4 years ago. The initial response and the final outcome using these parameters suggested by the American Thyroid Association were quite similar in both arms, those with thyroxine withdrawal and recombinant TSH. There are no significant differences. Anyway, look at in some cases, there are an increase, and also the incomplete was higher in thyroxine withdrawal than the other one. So there are some results that are pro the treatment using the recombinant TSH. And what about the stage 4, using this other, in this same paper, there were also no differences, but look at the excellent response, was much more higher, but in terms of initial response, in all groups, there were no significant differences. And what about the T4 tumors? Because we have high risk depending on the size of the tumor, depending on the presence of metastasis. Well, in this study published last year, they didn't find any differences according to the whole body scan and also the thyroglobulin, stimulated thyroglobulin in terms of response using both types of patient preparation. So what the guidelines say regarding, so we have mentioned the IAEA, but what about the British Thyroid Association? Well, they say that in these patients, there are no doubts. So with no metastasis, with a no lymph nodes metastasis, they have no doubts about. Again, they say that they have some doubts about the high-risk patients. And, well, pre-ablation scan is not included. This is part, and they mention the adequate renal function in these guidelines. And what about the IAEA? Well, as I mentioned before, they not consider in high risk, but they say that in patients with differentiated thyroid cancer with any risk, but comorbidity, they define comorbidity as a significant medical or psychiatric condition. Medical condition, what does it mean? Well, maybe most of the patients with metastasis had some medical condition comorbidity. So there is, in some way, from my opinion, a controversy about that. And also, this situation, I've never seen this situation in my life. So, but anyway, coming back to this possibility, significant medical or psychiatric could be used recombinant TSH. And what the Nuclear Medicine Society in Europe mentioned about that? Well, these guidelines were written or released in 2008, so it's far away. But they say something very, very, from my point of view, very reasonable, which is for now, which is also the time we are now, unless economically unfeasible, which is also something we have to take into account, the use of recombinant TSH is generally preferred to TSH stimulation method before radioiodine ablation with medium-large activities. And for ablation with smaller activities, either preparation method could be used. So these are my conclusion for this talk. Thank you.